This video continues Chapter 25 of OEC 6. We want to look at the assessment of patients who may have a cold injury. And so we'll focus on that assessment and we'll categorize 4 types of cold exposure. So again, a couple of terms that we'll see here is we'll talk a lot about frostbite and we'll talk about hypothermia and categorizing that very carefully. So with patient assessment, as always, the first thing as part of your scene size up is maintaining your own scene safety. Make sure that you do not become a patient as well. In the past, some ski patrollers would say, "Oh, hey, you're cold, let me help you," and give away their jacket. Don't do it. Move the patient inside to a warm environment. Use the blanket that's in the toboggan to keep them warm, but look out for yourself as well in that situation. Once you've established scene safety, again, proceed with primary assessment and managing any life threats to ABCDs. Remember, the cold injury may be a secondary injury, and you have illness or injury as a primary chief complaint that you need to address. You can examine the patient fully, get that correct patient history, and baseline vital signs. Look for signs of cold injury. And remember that your assessment can be completed in an efficient manner because you want to go ahead and move this patient inside. So more specifically, when you see frost nip, that individual's skin is going to be cool, it's going to be pale, it's going to be whitish. This is that superficial form of frostbite. It can be painful, but the skin will still be pliable and the tissues remain intact. As it progresses a little bit deeper in terms of frostbite, we're going to get some pain, but then that's followed by numbness without pain because we get freezing of the tissue and the sensation stops. Easing of pain can be mistaken for the condition improving. That's not true. It's getting worse. And so remember, frostbite should be suspected if that painfully cold body part stops hurting, but it's actually not getting warmer. You haven't moved inside or reduced the exposure. Along with that, those initially pliable tissues will start to get a little waxen, a little firm, a little woody to the touch, and that initial gray or whitish appearance starts to turn pale or red depending on the severity. If you can see it on someone's face or the tip of the nose or the ears, you may be the first person to see it before they notice it. Progression to deeper forms of frostbite often are accompanied by some blistering, and that's as the water in the tissues get moved into some of those interstitial spaces. So more specifically, we can look at cold exposure from a systemic point as well, not localized frost nip or frostbite, but these systemic things. And so remember, normal body temperature is about 37. So that is Celsius or 98.6 Fahrenheit. If you drop a little bit, you're going to start to stress the body systems. You'll respond by shivering in an effort to keep warm. Hypothermia is defined by the Heart Association as some core body temperature that's below 35 Celsius or 95 degrees Fahrenheit. In those first stages, when a person is cold stressed, heat is being lost by the body and metabolism is not keeping up. The output of heat is exceeding the input or the generation of heat. So we start to compensate, and one way that we compensate is by shivering. Mild hypothermia is where we categorize that core temperature below 95 Fahrenheit or 35 Celsius. And so we see that shivering increase to increase muscle activity and heat production. But unless other factors are present, typically the patient can manage that heat loss and elevate their core temperature through this compensatory mechanism. We have to protect them from further heat loss, and that could be by reducing the exposure, using that blanket in the toboggan, etc. When we move further into mild hypothermia, just remember that if we continue for that core temperature to fall, uncontrollable shivering is going to happen all the way down to a core temperature of 90 degrees Fahrenheit. That's 8.6 below what we consider kind of normal. If a patient is exhausted and they're unable to shiver, we'll see shivering stopping as well. We start to see the onset of some of these other things, confusion and decreased motor coordination. When we progress to moderate hypothermia, we're below 90 degrees Fahrenheit, and we'll see some other things show up, such as bradycardia. We get that peripheral vasoconstriction relaxing. This is an initial compensatory mechanism, and so consequently, hypotension results, a low blood pressure. The heart is beating slowly, that's bradycardia. The blood vessels are starting to relax and open up again, so consequently, the blood pressure will drop. These are the things that we see that are sometimes called the umbles. We get mumbles, we get bumbles or ataxia, and we get umbles, we get unresponsiveness as well. The surface temperature of the skin is getting colder. When we move to severe hypothermia, below 82 degrees Fahrenheit, the heart can actually end up in VFib, either spontaneously or in response to mechanical stimulation, moving the patient. So consequently, we handle them gently. In severe hypothermia, mental status is severely depressed. They're going to essentially be unresponsive. Now, the patient may appear clinically dead. They may be rigid. They may not have palpable pulses or discernible respirations. The torso is going to be cold to the touch. Their core area is actually going to be cold. Eye reflexes are going to be very, very diminished or absent. But one of the things that we used to say was, we can't assume they're dead until they're warm and dead. When we're out in the cold environment, they may just be very depressed in terms of their heart rate, in terms of their responses. But we want to just kind of continue with the warming and understand that the energy dependent processes metabolically are going to slow down significantly at this extremely low temperature. So we'll get successful resuscitation of some hypothermic victims who have very, very slow metabolic processes occurring as we warm them up. Be mindful of that. Make sure that a severely hypothermic victim, we handle them very gently and then proceed with warming.